presenters have been compensated for their time.
Welcome to Rapid Recaps, your place to explore the challenges of chronic spontaneous urticaria, or CSU, and learn more about RHAPSIDO, or remibrutinib. In each episode, experts share knowledge to help healthcare professionals like you navigate CSU management with confidence. My name is Dr. Michael Blaiss, and I'm joined by my colleagues specializing in CSU. Two leading experts from allergy and dermatology will share their insights on CSU, a condition that may present across specialties and in different clinical settings. Would you like to introduce yourselves?
Hello, I'm Dr. Priya Bansal.
And I'm Dr. Adam Friedman.
Welcome, and thank you for joining us.
Before we dive in, it's important to note that RHAPSIDO is indicated for the treatment of chronic spontaneous urticaria in adult patients who remain symptomatic despite H1 antihistamine treatment, and is not indicated for other forms of urticaria. The important safety information and a link to the full prescribing information can be found nearby this video. In this video, we'll explore data from the pivotal REMIX trials and discuss how RHAPSIDO has been shown to help manage the symptoms of CSU. As allergists and dermatologists, we understand the importance of having a demonstrated efficacy and a robust safety profile when considering treatment options. We'll start with a quick review of the study design for the REMIX trials and review the efficacy data. Dr. Friedman, take us away.
Absolutely. So the efficacy and safety of RHAPSIDO were evaluated in REMIX 1 and 2, the largest global phase 3 clinical trial program for a CSU treatment, which included over 900 patients. Here you can see the participating countries across the two trials.
And Dr. Bansal, what were the primary endpoints used to evaluate efficacy in these studies?
The efficacy of RHAPSIDO was assessed using patient-reported outcomes, or as we know, PROs. The co-primary endpoints were hive severity and itch severity over 7 days at week 12, measured as the least square means change from baseline. So hives and itch are frequently assessed in clinical practice, and these are very common to what we see as key measures of disease activity in CSU. HSS7 and ISS7 measure the daily number of hives and itch severity. The total score is calculated by summing the average daily hives and itch severity scores over 7 days, resulting in a combined score that ranges from 0 to 21.
Continuing on, let's discuss the efficacy results. As you can see in this table, both trials met their co-primary endpoints and showed similar reductions in hives and itch severity scores. Let's take a closer look at each of these endpoints and the results over time. Looking at these data, we can see that RHAPSIDO had a measurable change on patients in the trial.
So RHAPSIDO delivered fast relief from hives as demonstrated by significant reductions in HSS7 scores at week 12. While the LS mean change from baseline was negative 10.47 with RHAPSIDO versus negative 6 with placebo. Multiple imputation techniques were implemented to account for missing data. Now let's review results observed with RHAPSIDO from week 1 up until week 52. We will review this data first for hives and then itch. As you review these charts, please note that there are limitations to understand. No conclusions or comparisons can be drawn since post hoc or pre-specified exploratory analyses were performed at week 1 and weeks 12 and 24 respectively. These analyses were not adjusted for multiplicity. So at week 1, a 40% reduction in HSS7 was observed with RHAPSIDO versus 8% with placebo. At week 12, a 70% reduction in HSS7 was observed with RHAPSIDO versus 39% with placebo. At week 24, we're seeing a trend. A 74% reduction in HSS7 was observed with RHAPSIDO versus 48% with placebo. Remember, placebo still had antihistamines on board. After 24 weeks, all patients on placebo were crossed over to receive RHAPSIDO. Data after 24 should really be interpreted with caution due to the open label design and absence of a comparative control group. Week 52 data are a pre-specified exploratory analysis and no statistical tests were done. At week 52, patients who were randomized to the RHAPSIDO arm at baseline were observed to have a 77% reduction in HSS7. These results show that with RHAPSIDO, your appropriate patient can have a chance for relief from hives when antihistamines fall short, and can experience a significant reduction in symptoms at week 12. Results were observed as early as week 1 in a post-hoc analysis.
Moving on from hive severity to itch severity, Dr. Bansal, what was the impact there?
This is a really key area to call out because itch is often reported, especially by my patients, as the most bothersome symptom of CSU. So in the REMIX-2 study, RHAPSIDO delivered fast relief from itch as demonstrated by the significant reduction in ISS-7 scores at week 12, where the least squared mean reduction from baseline was negative 8.95 with RHAPSIDO versus negative 5.72 with placebo. Here you can see the efficacy of RHAPSIDO over the 52 weeks. Keeping in mind the limitations of this was observed data that was not adjusted for multiplicity, just as the last data that Dr. Friedman so kindly presented. So at week 1, 36% reduction in ISS-7 was observed with RHAPSIDO versus 6% placebo. At week 12, 67% reduction in ISS-7 observed with RHAPSIDO versus 42% with placebo. At week 24, 71% reduction in ISS-7 was observed with RHAPSIDO versus 47% with placebo. And then after this, again at week 52, during that open label period, an approximately 73% reduction in ISS-7 was observed with patients that were randomized to the RHAPSIDO arm at baseline. So again, looking at the data similar to the hives as measured by HSS-7, itch results measured by ISS-7 highlight the potential of RHAPSIDO for appropriate patients when, as you can clearly see, the antihistamines just aren't enough. By week 12, patients saw a significant reduction in symptoms. Results were observed as early as week 1 in a post-hoc analysis.
Now that we've reviewed the co-primary endpoint data from the REMIX trials, let's transition to another important conversation, the safety profile of RHAPSIDO. Dr. Friedman, can you take us through the safety findings from the clinical trials?
RHAPSIDO demonstrated a robust safety profile across 2 phase 3 trials up to 52 weeks. Now, this table here shows adverse reactions that occurred at greater than or equal to 3% phase 3 trials at week 24. That's where we still have that placebo arm. The most frequent adverse reactions were nasopharyngitis, bleeding, headache, nausea, and abdominal pain. In the pooled phase 3 trials, the safety profile of RHAPSIDO at 52 weeks was consistent with the safety profile at 24 weeks that you see here. Now let's take a little closer look at that bleeding, which I know you all want to hear about. The 9% of bleeding events were mucocutaneous related and no severe bleeding reactions occurred. Mucocutaneous bleeding events occurring in greater than or equal to 1% included petechiae, contusion, ecchymosis, and hematuria. Petechiae was reported in about 4% of patients treated with RHAPSIDO. Petechiae is considered a subset of skin and subcutaneous tissue disorders and is characterized by small, pinpoint, non-blanching red or purple spots caused by bleeding under the skin. Cases of petechiae were predominantly mild or moderate. Of the 23 patients who experienced petechiae while taking RHAPSIDO, only 1 discontinued treatment and no patients in the placebo group discontinued treatment. Other mucocutaneous events reported in less than 1% of cases among patients treated with RHAPSIDO included purpura, epistaxis, and conjunctival bleeding, gingival bleeding, hematoma, hemorrhagic ovarian cyst, intermenstrual bleeding, and urinary occult blood positive. No association between bleeding reactions and low platelet counts was observed. Of note, anticoagulant medications and antiplatelet medication, except for acetylsalicylic acid up to 100 milligrams a day, or clopidogrel up to 75 milligrams per day, were not allowed in the study. The use of dual antiplatelet therapy, like acetylsalicylic acid and clopidogrel, was prohibited.
So here's where a couple more call-outs come out as a note for you and your patients. And, you know, it bears repeating. Like, it's basically that there's no laboratory monitoring required, no boxed warning, or any contraindications. Also, RHAPSIDO, again, is a pill. It is not an injection or a steroid. In conclusion, RHAPSIDO met both co-primary endpoints, demonstrating efficacy in reducing hives and itch versus placebo at week 12. Demonstrated safety findings from 2 phase 3 trials through week 52 support RHAPSIDO as an option for your appropriate patients.
Indication: RHAPSIDO, remibrutinib, is indicated for the treatment of chronic spontaneous urticaria, CSU, in adult patients who remain symptomatic despite H1 antihistamine treatment. Limitations of use: RHAPSIDO is not indicated for other forms of urticaria. Important safety information. Warnings and precautions. Risk of bleeding. Mucocutaneous-related bleeding occurred in 9% of patients who received RHAPSIDO. Interrupt treatment with RHAPSIDO if bleeding is observed, and resume if the benefit is expected to outweigh the risk. Interrupt treatment with RHAPSIDO for 3 to 7 days pre- and post-surgery or invasive procedures. Use of antithrombotic agents concomitantly with RHAPSIDO may further increase the risk of bleeding. Consider the benefits and risks of antithrombotic agents when used with RHAPSIDO. Monitor for signs and symptoms of bleeding. The use of live and live-attenuated vaccines should be avoided in patients receiving RHAPSIDO. Adverse reactions. The most common adverse reactions, incidence greater than or equal to 3%, were nasopharyngitis, bleeding, headache, nausea, and abdominal pain. Drug interactions. Remibrutinib is a CYP3A4 substrate and a P-glycoprotein (PGP) inhibitor. Avoid use of RHAPSIDO with strong or moderate CYP3A4 inhibitors. Concomitant use with a strong or moderate CYP3A4 inhibitor increases remibrutinib exposure, which may increase the risk of RHAPSIDO adverse reactions. Avoid use of RHAPSIDO with strong or moderate CYP3A4 inducers. Concomitant use with a strong or moderate CYP3A4 inducer decreases remibrutinib exposure, which may decrease the efficacy of RHAPSIDO. Monitor more frequently for adverse reactions when using RHAPSIDO with PGP substrates where minimal concentration changes may lead to serious adverse reactions, for example, digoxin. Remibrutinib increases exposure of PGP substrates, which may increase the risk of adverse reactions related to PGP substrates. No data are available on concomitant use of RHAPSIDO with anticoagulants. The concomitant use of RHAPSIDO and anticoagulants was not allowed in clinical studies. Use of the antiplatelet agents acetylsalicylic acid at doses up to 100 milligrams daily or clopidogrel up to 75 milligrams daily was allowed in the RHAPSIDO clinical studies. Use in specific populations. There is a pregnancy exposure registry that monitors pregnancy outcomes in women exposed to RHAPSIDO during pregnancy. Avoid use of RHAPSIDO in patients with mild, moderate, or severe hepatic impairment, Child-Pugh Class A, B, and C. RHAPSIDO exposure is increased in these patients relative to patients with normal hepatic function.
This wraps up this video. Thank you for watching Rapid Recaps on RHAPSIDO. We invite you to explore the other videos in the series to learn more about RHAPSIDO and its role in CSU treatment. Explore clinical insights and treatment considerations for CSU at rhapsido-hcp.com.